Thanks for your introduction. I'm Chen from Taiwan, Tainan. I'm very happy can come here to have a lecture. And my topic will be severe dengue fever. What's the role of intensivist? Here is my outline. Is some general conception and the grading system, diagnosis, and the hemodynamic clinical feature, and the bacteremia, and the other therapy. Okay, let's move to the first part, general concept and global incidence of dengue. Here we know dengue is caused by mosquito-borne fever virus, and most of the patient was asymptomatic, but some have fever, headache, breathing, joint pain, but some have a severe plasma leakage and cause hypotension, pleural effusion, and the GI bleeding. And it was ranked by WHO as the first most important mosquito-borne virus infection. We have 4 types so far know about that. Here is the skin rash in dengue. We can see some skin rash, and the characteristic could be some white iron in a Red Sea. Here is the example of my patient, the plasma leakage in severe dengue. It's caused by capillary permeability change with extended leakage and without any endothelial damage. Maybe caused by immunocomplex and maybe some antibiotic reaction, maybe some caused by secondary infection. And here is the global incidence of dengue, increased about 34 in the past 50 years. And here is the global distribution of dengue. We know it's around the tropic, subtropic area. It was estimated about 3 billion people was at risk, and about 20,000 people was dead by this kind of disease. And the annual cost may be higher as $9 billion US dollars, and higher than Korea and the other GI symptom. Why? It will cause some global burden, maybe due because of the increased population density, maybe due to global warming, maybe due to rapid urbanization, and maybe due to the industry develop and some waste tire and the water outside, so help the mosquito to grow. Here is the WHO guide about the different country. I think the Brazil, maybe about 500,000 people will get infection, and some like Vietnam, Thailand. So it's a disease. Lots of in tropic and subtropic area can occur this kind of disease. Here we have an outbreak in Taiwan, Tainan in 2015, and about 44,000 patients get infection. Especially my city, resident city, Tainan, is near the tropic cancer area, and about lots of people get infection. So here is the example in our emergency room. Lots of patients was put on the mosquito net, and there's a joke. When you travel to Tainan, you must put this kind of equipment to protect yourself, to protect your kids, like a Kung Fu master, like that. And here is my master. Here is the mayor of Tainan city. He is also a doctor, and he will be maybe the next president of Taiwan. He was so hurried about the mosquito outbreak, dengue, something like that. Yeah. So the grading of dengue, we range from WHO 1997 to 2009. Why change? Because in the past, the WHO definition of 1997 is based on the about 40 or 50 years ago from Thailand, Bangkok, some children's experience. They define the disease as some undifferential fever or dengue fever, or some caused by plasma leakage syndrome like dengue hemorrhagic fever or dengue shock syndrome. But now we classify into the 2009 definition based on the warming sign, so classify as group A, B, C. Here is the simple definition of dengue based on WHO 1997. If you have a positive sign for tourniquet test, then you can grade 1, 2, 3, 4, maybe due to severe plasma leakage syndrome. Here is the relative new definition in WHO 2009. We based on if you have a dengue, suspicious dengue infection, and have some sign, but you don't have to admit to ward, just OPD follow-up, is group A. And if you have following sign, warming sign, like abdominal pain, like a clinical fluid accumulation, like mucosa bleeding, and especially some group like pregnant or some old patient, you will be grouped as groups B, and you need ward admission. And if you have a severe plasma leakage syndrome, like ARDS, like severe bleeding, like abnormal liver function, you will group as a group C, and you need ICU admission at that time. Why we make a difference? Because it's based on different definition. And the same patient, if you define by old definition, most people will be like a dengue fever, nothing happened. But you based on the two new definition, lots of people will group on group B, group C, and the sensitivity different. If you categorize the category 3 is a more severe patient, the sensitivity for the old definition will be only 39%. But if you use a new definition, the sensitivity will be higher. So it's easier for ER triage to group the severe patient. So what about the diagnosis of clinical cause of dengue? We can do some laboratory confirmed dengue by viral isolation, by PCR, by non-structural protein 1, NS1, and also indirect by IgG, IgM. Here is the clinical cause. The dengue will have a biphasic fever. At the beginning, maybe you have 40 degrees Celsius, very high, and later, about 3 days later, the fever temperature goes down and again get higher. But if fever goes down, you should not say nothing. You should care about the platelet count. If platelet count goes down and the HCT go higher, it means hemo concentration. It would be critical phase. That means maybe plasma leakage occurred. So here's the example of serology. If you have IgG, IgM positive with NS1 positive, it will be at the critical phase. Should be care about that. So here is some example of critical day of severe dengue. Day 1, you have a platelet count, seems okay, still fine, okay. But at day 4, the platelet count go down to very low degree, then gradually getting higher. It will be the critical phase on day 4. Here is some example of a patient with plasma leakage. We can see the platelet count goes down and the HCT getting higher, means hemo concentration and the plasma leakage. And the other case, maybe we will not have a plasma leakage because of the hemo concentration, HCT is getting normal, although the platelet count is lower at the time. So what about the hemodynamic support of dengue? Based on the guideline, WHO guideline, we know dengue may be due to plasma leakage. So lots of people have hemorrhagic shock, but some will have cardiogenic shock. If we have a bacteremia, they will become a septic shock. So the guideline maybe asks us to survey HCT level and do resuscitation. Usually, for my personal experience, I will use Cristalol about 20 cc per kilo, very quick, rapid resuscitation. If everything get improvement, they will taper down our free level, gradually tap down. If nothing happen at the not improvement, maybe we'll check HCT again. If HCT getting higher, mean hemo concentration and plasma leakage, maybe we need more free resuscitation again. And if not useful, maybe I will try color at that time. After 30 cc per kilo resuscitation, for my personal experience, I will do that and see what happened. If initially the HCT didn't get in higher, it become lower. So you must be careful about maybe bleeding, plasma leakage. So you must do some blood transfusion of whole blood at that time. So it's my personal experience at the beginning, at the acute phase, maybe for resuscitation, you can use Cristalol. But at the critical phase, maybe you must consider about Cristalol plus some colloidal. And the direct should be very, very careful because it may cause some hypertension. Although at that time, you can see pulmonary edema. But you know, lung edema doesn't mean your intravascular is adequate. So you must be careful about that. So here is the dynamic change of free therapy for my own patient. We can see from the bottom, at the critical phase 1, here we have a higher concentration SCT, no lung edema, but has shock. I think Cristalol at that time is better. Then we keep on resuscitate and the HCT getting normal, and maybe we hold the fluid at that time. But the next day we find HCT getting higher, so hemo concentration, but lung edema, and we have shock. What happened to that time? Maybe we still have some colloidal to use, but no direct still. And in Chinese word, we say, seawater is not water. It's not true water, because intravascular is not adequate at that time. As times go by, we do resuscitate, and the shock stage gradually improve. So maybe hold the fluid and maybe attach some colloid plus some diuretic to help to improve the lung edema. So we need the teamwork for dengue outbreak. For me, attending doctor, a leader, for resident, do some insertion. For some nurse, we can do the assist or education, evaluation. We need a pharmacy, we need a dietitian, we need a RT. Also, we need the PT. Like this, we can help people to do early mobilization, to early intubation at the time. So we are teamwork for dengue treatment. So what about the clinical feature and the critical dengue? Here we have lots of posters in Chinese form, in English form, talk about to pay attention about the dengue fever. And the dengue could be multi-organ involvement, like this one. Maybe we have encephalopathy, ICH, Guillain-Barré syndrome, transverse myelitis. Also, you can have a myocarditis or Takotsubo cardiomyopathy, some conduction abnormal. And the lung ARDS is for sure, and the pulmonary hemorrhage. Also, we can cause fulminant hepatic failure, acute pancreatitis, acute renal injury, and myositis, rhabdomyolysis, also hemophagocytosis syndrome, everything you can see. Here's some example, my patient, ICH, ARDS, rhabdomyolysis, pleural effusion, retinal hemorrhage, calculus cholecystitis, and pancreatitis, all occur after dengue outbreak. So the clinical feature of critical dengue. Now, we find it shifts the epidemiology from pediatric to adult, and more than 85% have less platelet count, and the average year admitted to ICU will be about 42 years old, and the more are male, and half of the patients have comorbidity like DM, hypertension. The mortality rate will be as high as 20%. It's very high. It's according to a recent publication. Here is my own study, my own study about published in Medicine last year, and we have outbreak in 2015, and there's about 143 patients admit, group C patient admit to my ICU. The average year is about 70 years old, and the mortality as high as 23%, very high at the time. But for all hospital admissions, only 0.7%. And we can see the age from 60 to 69 have a higher mortality for my patient. And we can find some predictive factor like coma scale is lower or platelet count is lower, and the multi-organ rate can predict the mortality rate. Here is some paper talk about similar study like a higher SOFA approach and the higher latte label, low albumin label, and the multi-organ failure. Even patients do some peritoneal dialysis also have a higher mortality rate. What about the dengue with bacteremia? It's not certain thing. According to some study from Singapore, they do about 5 years study. There's around 10,000 dengue patients admitted to their hospital, and only 0.3 have bacterial infection. And the most common thing is Staphylococcus, Salmonella, and the E. coli for their study. And for my own study, recent published in the other paper, is also from the data from the outbreak. The group C data, we can find about a higher percentage of bacteremia, about 60% have bacteremia. And the most common thing still Streptococcus, E. coli, and the Staphylococcus aureus. And we can find, compared to those patients dengue without bacteremia, we have a higher mortality rate. And if we compare the same period, match control patient with bacteremia but no dengue, we can find the organ is different. You know, it's higher in GPC for dengue with bacteremia. So what about the other therapy for dengue? So the guideline for transfusion for dengue fever, prophylaxis transfusion platelet is not recommendation for patient. It doesn't prevent bleeding. So for my own personal experience from guideline, I think more than 20,000 it's enough. It's enough. So this is from the other study from +1, PLUS study, and from last year published in the PLUS. And they collect the data from about 800 person, and they think about blood transfusion platelet doesn't have any effect on breathing, but they can prolong the hospital stay. So I think prophylaxis transfusion of platelet platelet is not recommendation for the experience. So what about the therapeutic trial in dengue? Lots of drugs like a steroid, like immunoglobulin, doxycycline, and chloroquine, and some antivirus therapy. So far, from my study, literature review, I didn't find any beneficial effect for this kind of patient. So very quick, I have some take-home message for everybody. We know about the dengue, the incidence increase, maybe due to the globalization, maybe due to urbanization and the climate change. And the dengue can range from asymptomatic to, it's about, most patients are asymptomatic, 95% is asymptomatic, but some will have mild or severe symptoms and may cause bleeding, may cause plasma leakage or multi-organ failure. And the WHO revised from 1997 is based on the pediatric patient to so far 2009 is based on adult patient, and within the population shift from a pediatric to adult recently for my personal experience. And the free therapy should be very careful and crystallocolloidal. And for my experience, I think about it didn't like a septic shock, because septic shock we need some time, critical phase maybe 3 or 4 days to do resuscitation and to do diuretic use again. But for dengue, it's very rapid. Maybe 1-2 day resuscitation, then become better, then do diuretic use. So very quicker than sepsis. And prophylaxis to transfuse a platelet is now is unfound. So I don't think about we need to prophylaxis to transfuse platelet count. And also, you must survey the concurrent bacteremia because it causes high mortality rate. Yeah, and the other therapy like steroid, like immunoglobulin, and the antivirus therapy doesn't have any benefit. And we need a teamwork to do dengue treatment. So here is my country, from Taiwan, Tainan, and welcome everybody to Tainan. And maybe we can have a game like play golf, like to share the seafood, and visit my museum and everything. Thank you.